Now we are coming to our next session. This session is being sponsored by MRI Dhakuria, and this is on a very important topic, epilepsy. So our eminent speaker is Dr. Koushik Dutta.
So, drug-resistant epilepsies are basically a very challenging aspect of our epilepsy management. Since the treatment gap for epilepsy and any other neurological disorder is lot in Asian countries, including India, most of the epilepsy cases will first go to the physician, not to the neurologist, and only the neurologists cannot, it's not possible to treat all our epilepsy patients by the neurologist only. So the physician has to be very aware of the epilepsies. But the challenging aspect is when you have used 1, 2, or more number of drugs and still the epilepsy is not responding, the seizures are not coming down. So what do you mean by a drug-resistant epilepsy? And my focus will be mainly on the medical therapies with a brief mention of the surgical aspects. So drug resistance means that you are not being able to control the seizures with an adequate trial of at least 2 anti-seizure medications. Previously we called them anti-epileptic, but most of them just control seizures, do not have any disease-modifying effect, so they are now called anti-seizure medications. So you have given 2 properly chosen anti-epileptics. Properly chosen is according to the syndrome, and there should be adequate dose, adequate trial of 2 anti-epileptics. If the patient is not responding, then you can call it drug-resistant epilepsy. Previously, we used the term intractable, but now drug-resistant is used because they can be treated in other ways later on. And what we can aim is, actually we aim for complete seizure freedom. But if it is not possible, then you can aim for 70% or 50% seizure reduction, or in some patients, at least you can control the generalized seizures if the focal seizures still continue to happen. So when you are talking about drug-resistant epilepsies, you have to be sure that why the epilepsy has become drug-resistant. It may be due to the disease etiology itself, the genetic factors, the comorbidities, some inflammatory responses inside the brain, alteration of the blood-brain barrier, the drug-related factors, pharmacokinetic alterations of the drugs and the epilepsies, drugs in the periphery and the epilepsies also, because the epileptogenic cells, they can behave like bacterial cells and can evolve mechanisms of drug resistance like drug efflux transporter alterations or drug target alterations. So, which was previously responsive can later become unresponsive to those drugs. And there may be morphological alterations of the network on which the epilepsy is dependent. Previously, we thought that one focus is responsible for generation of the epilepsy, but now we find that many of the epilepsies are basically dependent on networks, how all the foci are talking with each other. So networks may alter and the epilepsy may become resistant, and the worsening patterns of epilepsy, it has got a natural history of worsening, and the severity of epilepsy to start with. And when you think about the risk factors of resistance, the symptomatic epilepsies which have lesions inside, the abnormal neuroimaging, abnormal EEG, because EEG can be normal in many of the epilepsy patients, but if the EEG is abnormal and it continues to be abnormal for a few days even after treatment, then the epilepsy can become resistant. The history of mental retardation, other psychiatric disorders, and history of prolonged febrile seizures in childhood, and the history of status epilepticus very early in the epilepsy are all bad prognostic factors. Now, there can be 4 patterns of resistance. Some epilepsies are de novo resistant, resistance ab initio. That is, they are resistant to therapy from the beginning. They do not respond. Some patients initially become seizure-free, and then the seizures recur and become uncontrolled. Some patients may have a waxing waning pattern, good control, bad control, add another drug, again good control, again bad control. So this is waxing waning pattern. And some epilepsies rarely may be initially resistant to drugs, but with a combination later on, they may come down. So these are, unfortunately, this is a smaller group. So when you are calling some epilepsy drug resistant, before that you have to be sure that you have used at least 2 properly chosen anti-seizure drugs with adequate doses for adequate time, and only 50% of the patients with uncontrolled seizures actually met the ILAE, International League Against Epilepsy's criteria for drug-resistant epilepsy. So uncontrolled doesn't mean drug-resistant. And there can be pseudo-resistances due to various factors. One important factor is psychological. That is psychogenic non-epileptic seizures. They may mimic epilepsies, and that can be responsible for at least 20 to 25% of the apparently uncontrolled seizures. So why there is the intractability apparently? It can be a misdiagnosis. It can be an inappropriate dose, non-adherence from the patient's part, or other lifestyle factors like consumption of substances, and not sleeping adequately, and psychogenic factors I have told, and other non-epileptic paroxysmal events like, say, kinesiogenic dyskinesia. Those are certain movement disorders which may mimic epilepsies. So why this is very important? Because the mortality increases when the patient is having drug-resistant epilepsies, and the chances of SUDEP, that is sudden unexpected death in epilepsy, that goes up 40-folds, 40 times higher than an other epileptic patient who is not drug resistant. And of course, there is a decreased quality of life, poor social activity, poor career, poor confidence, studies are lost, and the entire career is damaged. So workup is properly very important. You have to recognize the seizure type properly, then classify it in a syndrome. And if you choose the drugs appropriately for the seizure type and the syndrome, then the chances of success are much more. An inappropriately chosen drug will not give you the result. And determine the intractability properly according to criteria. And for that, studying the semiology and the history in detail and examining the patient may sometimes be very important. So when managing such epilepsies, what you can do, you have broad spectrum AEDs which may be useful when you are still not very able to classify it properly. You can use these valproate, levetiracetam, topiramate, sonisamide, lamotrigine, all the broad spectrum ones. And the newly approved drugs have added to the platter and have increased the rate of success to some extent, which include perampanel, brivaracetam, lacosamide, with which you are all well-versed by now. But that also includes drugs like rufinamide. Clobazam can be used for Lennox-Gastaut, everolimus or vigabatrin for the tuberous sclerosis, stiripentol for Dravet, and cannabidiol, which is a cannabis derivative that can also be used in certain types of epilepsies. When drugs are not alone sufficient, you can go for the diet and the surgical options. Among the diet, all are basically low carbohydrate, high fat diets, which are basically ketogenic. It can be modified Atkins diet or low glycemic index treatment also. And among the surgical options, you can go for vagal nerve stimulation. You can go for a lesionectomy if the lesion can be identified, which has been identified as a proper epileptogenic lesion. There can be just innocent bystander lesions. If you resect that, there will be no benefit. And if nothing can be done and there are too many generalized seizures, you can do a corpus callosotomy so that the hemispheres are separated from each other. They cannot cross-talk. And the generalized aspects of the seizures, the GTCS, may be controlled, which will give you some relief. So when you are adding another drug or adding a good number of drugs, you have to start low and go slow gradually. Because if there are early side effects, the patient may drop out and the patient may be incompliant. And when a drug has failed already, you may reduce its dose or take it out altogether. And in patients requiring polytherapy, seizure freedom is achievable with polytherapy. You don't have to stick to monotherapy. But there should be a rational approach to combine the drugs. There should be combination of drugs with different mechanisms of action. If drugs have synergistic effects like valproate and lamotrigine, that is a very good combination, or carbamazepine and clobazam for the focal seizures, those are very good combinations. And if they don't have the synergistic effect, or if they have the same mechanism of action and the same side effect profile, then preferably avoid those combinations, because that will give a negative result and the patient will drop out. Now see, there was a seminal paper by Kwon and Brody that said that 45% patients will respond to the first drug, then it comes down to 11%, then it comes down to 5% with the third drug. But later a paper was published in 2018. This paper was Kwan and Brody's seminal paper was in 2006, and this paper of 2018 shows that even after adding the third drug, 23.6% patients have achieved seizure freedom. So the treatment has improved over the years. And the second AED addition may be a substitution monotherapy. You withdraw the first one, give the second one, or a rational polytherapy, as I have said already. And I have discussed all these points, combination, how to combine the things. So when the initial monotherapy has failed, add a second therapy as a monotherapy or add on according to your preference. Then if it is failed, then refer to a tertiary epilepsy care center, and the proper diagnostic evaluation, including a video EEG, a properly done epilepsy protocol, MRI, preferably high Tesla MRI, and then we do ictal SPECT or interictal PET to localize the things. If we can corroborate all these things, like the semiology of the ictus, the seizures, corroborate with the MRI findings, with the EEG findings, the video EEG findings, then we can find out a resectable lesion. We can go for resective surgery, or we can go for additional drug trials, or neurostimulatory approaches like DBS, and other dietary approaches. Now, there are certain recommendations. You cannot memorize this because these are all available, but overall, if it is a focal seizure, you can start with carbamazepine and those groups. Gabapentin we don't use in India because the dose requirement is very high and most of our patients are not able to tolerate such high doses. And for primarily generalized tonic-clonic seizures, according to the SANA-2 trial, if it is a primary generalized epilepsy, valproate is probably the best drug if the patient has no contraindication. Then you have levetiracetam, lamotrigine, and other drugs also. For myoclonic generalized seizures, it's basically valproate, the first one. Then you can go for the add-on drugs. These charts are available over the internet. You can just use it when you are practicing. And for atonic tonic seizures, generalized onset valproate, again, you can combine lamotrigine. And for absence, typically we use either ethosuximide or valproate. If one fails, then the other can be added. And lamotrigine can also sometimes be used, clonazepam and clobazam also, later on. So what are the factors in various age groups that will predict that this patient may have drug-resistant epilepsy? In children, that is the infants less than 1 year age, symptomatic epilepsy is mental retardation, that is poor developmental milestones, overall delay, and the pathological neurological imaging, abnormal neuroimaging, these are all factors that lead to drug resistance. In older children, weekly seizures for the first year off treatment and weekly seizures before the treatment onset. And if in adolescents, it's a focal epilepsy or mental retardation and psychiatric comorbidities at present, then you are heading for a potentially drug-resistant case. And in adults also, if these are symptomatic focal seizures, initial unconsciousness during the seizures, and multiple seizure types in the same patient, tonic akinetic seizures or abnormalities in the EEG are found in recurrently, then this patient is going to be drug resistant. So you have to rationalize your therapy and approach the patient in a more stringent way. So what we do is combining AEDs with different mechanism of action, avoiding similar toxicity profile, consider more than 2 AEDs but rationally combine them, and customizing the therapy for the type of epilepsy and the epilepsy syndrome. This is very important, otherwise it will lead to a failure. Why? Because there are certain drugs which can increase the seizures. For example, if you are using carbamazepine in absence seizures, myoclonic, JME, juvenile myoclonic epilepsies, then certainly the seizure is going to increase. So this sort of phenytoin also will increase seizures in this sort of epilepsies. So this is just to give you an overview that improperly chosen drug can actually worsen the epilepsy. So not all anti-epileptics are meant for all epilepsies. You have to choose the drug according to the syndrome. And then there are certain combinations which are useful. For example, if you're treating childhood absence epilepsy not responding to valproate, you can add ethosuximide. If you're treating JME, you can add lamotrigine to valproate. And if you're treating a focal epilepsy, start with carbamazepine, add clobazam, or start with lacosamide, add another AEG which is not a sodium channel blocker. So in this sort, you can combine drugs properly to have added benefits. But if you use these combinations where multiple sedative things like, say, phenytoin is very often combined with phenobarbital or carbamazepine with phenobarbital, but these patients will need monitoring, otherwise they may worsen. And so certain drugs you need to monitor very clearly, repeatedly, and there are certain drugs combinations which are not useful and not recommended. For example, you combine phenobarbital with another sedative benzodiazepine. That will only increase the sedation, not control, because the mechanism of action is same and sedation is too much. Carbamazepine, phenytoin, both are sodium channel blockers. That will increase the ataxia, increase the side effect profile, liver toxicity, but no improvement. If one drug has failed, the second drug will not help. So such combinations should be avoided. So when you are dealing with such a case of resistant epilepsy, first look for the diagnostic error or inappropriately chosen drug or inappropriate dose, and then refer to a proper epilepsy treatment center, and then a video EEG monitoring has to be done to see the semiology and correlate. For example, the patient is having a psychogenic non-epileptic seizures. Then if I do the video EEG, the semiology of the seizure will be seen, but at the same time the EEG is being done, the EEG will be normal. So you're sure that these movements, abnormal movements, have no correlation with the EEGs. But if the movement starts, abnormal seizure-like movement starts, and you see that the same semiology in each seizure type, very stereotyped semiology, and in every case there is an EEG change and modulation and ictal discharges are coming, then you are sure this is an epilepsy. Then from where it is coming, from where it is starting, because it will spread to the brain, entire brain. So being able to see the onset of the seizure and the onset of the EEG changes, these will give you the localization. Now, if the localization from these, the semiology, the EEG localization, your MRI localization, or PET or SPECT localization, they are all the same, then you are sure that this epilepsy is coming from that area. And we have certain new approaches of drug treatment also for these patients, which are not very commonly used. Broad spectrum AEDs I've already discussed, but important genetic metabolic modifications can now be done. For example, if you have a tuberous sclerosis patient who had West syndrome, then Lennox-Gastaut syndrome, then you can inhibit the mTOR pathway with everolimus. That can give you a good result. If it is a GLUT1 deficiency, then ketogenic diet is as primary as drugs. You have to use a ketogenic drug for that patient. If in Dravet syndrome, you can use fenfluramine to correct the serotonin deficiency in those patients. And certain bumetanide may be used in certain cases. So these are all new approaches that can be used in addition to traditional anti-epileptics. And then you can go for epilepsy surgery or neurostimulation.
So 2 minutes left.
Yeah. So, and finally, if nothing is working, you can go for the surgery. I have already talked about the workup. I'll briefly show one case and stop there. This is a young man, right-handed, with no comorbidity, with good birth and normal development history, and the onset was at 18 years, having very frequent seizures with multiple seizures per day. So this patient's semiology was first studied, and the patient we found that it is probably an extratemporal right hemispheric location, probably the frontal lobe from the semiology. Then we excluded all the comorbidities. Then an interictal EEG showed that the spikes are coming from the same location that we suspected. Then we did a video EEG and we studied the seizures, and we could locate at the same location as the semiology and the interictal discharges. Then we did the MRI brain, and we could see this, see just lateral to the midline in the frontal lobe. You can see this lesion, which will be more clear in this picture, the white one here. This is a T2 axial that will give you the whiteness. And we could see that everything is corroborating. MRI, EEG, video EEG, semiology, everything is corroborating to the same area, and the MRS spectroscopy said that this is a benign lesion. So we categorized this patient in various axes, and finally we proceeded. So the patient didn't respond to multiple anti-epileptic drugs, so we did a surgery. A lesionectomy was done through the right frontal craniotomy approach, and postoperatively in biopsy, you have seen it was a cortical dysplasia type 1B. And in follow-up, the patient was maintained on 2 antiepileptics for 2 years, and the patient was completely seizure-free. Then the antiepileptics were gradually tapered. So don't stop the antiepileptics immediately after the surgery. You have to maintain on that for at least 1 to 2 years. And with that, I stopped because this was a very simple case, easy to diagnose and easy to operate. But in all cases, the decision-making may not be so easy. But the message is many of the drug-resistant, previously intractable epilepsies are now tractable. And those are treatable, and the patient can still have a good quality of life. Thank you all.
Thank you.
Thank you very much. Sir, please come up, sir. Dr. Dutta, please. Thank you very much. Now, I will request our chairpersons to felicitate Dr. Dutta. Excellent speech. This session was sponsored by AMRI Dhakuria. Now we conclude our fourth session.